Post-stroke and diabetes medication, understanding trends before numbers look abnormal. Number 1520, BPT077, the 1st of February 2026. Gerald C. EclaireMD Foundation. Category, Stroke and Diabetes. Preface, I want to share my observations of my post-stroke diabetes condition using a plain language, patient-facing version for other patients who have faced similar situations. I try to keep the core truth, remove technical framing, and focus on helping people notice early warning signals before numbers cross official thresholds. Introduction. After my stroke on June 21, 2025, I learned an important lesson that may help other patients. Numbers alone do not tell the whole story. Direction matters. Trend matters. How your body responds over time matters more than whether you are just above or below a medical cutoff. This article is written for patients, not doctors. It is shared through YouTube, not medical journals or conferences. Its purpose is simple: to help you recognize early warning signals in your health before problems become obvious on lab reports. My baseline before stroke, from 2010 to mid-2025, I took no medications at all, no diabetes drugs, no supplements, not even vitamins. During those 15 years, I controlled my glucose entirely through daily lifestyle habits such as food portion control, walking, and regular routines. Why separating phases matters. I was trained as an engineer. In engineering, experiments are done one variable at a time. You change one input, keep everything else stable, and observe how the output responds. That is how cause and effect become clear. In medicine, I use the same principle. I use my own body as a living laboratory. Over 37 years, I have observed how my body responds to lifestyle changes and medications under clearly separated conditions. This long separation in time allows meaningful comparison. My health journey can be divided into 3 distinct phases. The first phase, from 1990 to 2009, relied primarily on diabetes medications. Lifestyle control was not my main tool due to demanding CEO responsibilities. Drug effects dominated system behavior. This 20-year period of diabetes gradually contributed to calcification in my brain blood vessels. The second phase began in 2010, when I stepped away from business responsibilities and stopped all medications and supplements. For the next 15.5 years, until June 2025, I controlled my glucose and overall health entirely through lifestyle management. This phase established a long, stable, medication-free baseline. My body responses were predictable and responsive, showing strong internal reserve. These efforts played a major role in preserving my health and extending my lifespan. Unfortunately, an acute blood pressure spike to 175 mmHg on June 21, 2025 triggered my hemorrhagic stroke at the Pontine location. The third phase began after my stroke on June 21, 2025 and continued through January 31, 2026. During this period, I used both lifestyle management and medication, specifically metformin at doses between 500 mg and 1000 mg, while sleeping more and walking fewer steps. This is the first time in my life that these 2 inputs were applied together. Because these 3 phases are clearly separated in time, I can observe how my metabolic system behaves under drug-only control, lifestyle-only control, and combined control. The changes I observe after the stroke are not random noise. They reflect a system that has moved into a new operating state. This long-term, phased observation helps me understand not just numbers, but how my body adapts, compensates, and gradually loses reserve over time. It also explains why trends and trajectories matter more than single measurements, especially after a major event such as a stroke. Of course, I also understand that aging has played a role in these changes. Focusing on diabetes during the post-stroke period before my stroke, my glucose behaved predictably. When it rose, lifestyle changes brought it back down. My body had reserve and could correct itself. After the stroke, several changes occurred at the same time. I became tired more easily. I could not walk as much as before. I needed more sleep. My glucose became harder to control and fluctuated more. Even though average glucose values remained below the threshold of 114 mg DL/HbA1c 5.7%, these were not choices. They were signals from my body. I chose not to fight them. Pushing too hard risks damaging a weakened body and brain system. Recovery is not about forcing your body to behave as it did before. It is about learning what it can safely do now. Starting metformin after stroke. I started metformin only after my stroke. At first, a higher dose lowered my glucose too much. When I reduced the dose, glucose rose again. When I increased it back, glucose continued to drift upward. This raised a natural concern. Was the medication causing problems? Based on my data, the answer is no. The stroke caused the major change. Metformin did not damage my system. It became more visible because other control mechanisms, such as exercise, were weakened. Why weekly glucose ups and downs matter? After the stroke, my weekly average glucose fluctuated more than before. These changes followed medication adjustments more than diet or exercise. My diet quality, carbohydrate, and sugar intake remained largely unchanged, except that I shifted from 3 meals to 2 meals per day, brunch and dinner. This is an important signal. When lifestyle changes stop working as well as before, it does not mean failure. It means reduced metabolic reserve. To patients, this may feel like randomness. Living systems are not random. When patterns break down, underlying structure has shifted. Glucose thresholds are not the goal. Many patients are told not to worry as long as numbers remain below cutoffs such as 114 mg/dl for average glucose or 5.7% HbA1c. I stayed below these values, yet remained concerned. My glucose showed a slow upward drift and became harder to reverse. Trend matters more than a single number. It is like driving uphill. You may be below the speed limit, but if the engine strains more, something has changed. Loss of energy reserve is the realest way. Before my stroke, my body could handle stress and recover. After the stroke, recovery became slower and sometimes incomplete. This reflects a loss of energy reserve. It happens quietly. Doctors may not notice it, but patients can feel it. Common signs include needing more sleep, getting tired faster, slower recovery from setbacks, and medications having stronger or less predictable effects. These signs often appear before lab values become abnormal. Why this is not anyone's fault. Doctors are trained to look at snapshots. Patients live inside a moving system and can feel its trajectory, even when they cannot measure it or see the curve. This gap is not due to bad doctors or bad patients. It reflects a limitation in how modern medicine measures human health, rooted in gaps in scientific and academic foundations. Paying attention to trends allows earlier self-protection. What patients can learn: do not focus only on passing or failing a threshold. Watch direction and change over time. Notice whether recovery is slower than before. Respect fatigue and increase sleep needs. Do not force old exercise standards after a major event. Calm attention, not panic. I am not afraid. Data brings clarity. Understanding trends brings calm. The goal is not perfect control, but stability, safety, and gradual recovery. If something feels different even when numbers look acceptable, trust that signal. Important changes often appear in trajectory long before thresholds are crossed. Listening early can prevent bigger problems later. VPT analysis results post-stroke period. I conducted a viscoplast topology VPT analysis using EG as the output strain and 3 input stressors: sleep hours, walking steps, and food quantity and quality across 7 monthly post-stroke periods. Normalization factors were sleep 8 hours, walking 6,000 steps, food 0.6 or 60% of normal intake. Using the viscoplastic medicine theory VMT energy model, energy contributions were sleep 41%, steps 31%, food 28%. Topological data analysis TD included a time-ordered 3D scatter diagram across all 7 months and a radar chart comparing beginning, middle, and ending periods. Key observations: post-stroke glucose control structure changed. Diet is no longer the dominant factor. Sleep contributes the largest VMT energy share, 41%. Walking steps remain influential but constrained, 31%. Food contribution decreased to 28% post-stroke. TDA 3D scatter shows loss of linear structure. Monthly points form a directional trajectory, not random scatter. Radar charts show structural reshaping over time. Cumulative VMT energy accelerates after October 2025. AG remains below 119 mg/dl, HbA1c 5.86% except January 2026 at 121 mg/dl, HbA1c 5.9%. Post-stroke glucose management must prioritize sleep and realistic activity over further diet tightening. Conclusion: my post-stroke experience has taught me that diabetes management cannot be judged by numbers alone. Remaining below traditional glucose thresholds does not guarantee stability. especially after a major event such as a stroke. Direction, variability, and recovery capacity matter as much as absolute values. Before my stroke, lifestyle control was sufficient because my body still had reserve. After the stroke, that reserve was reduced, sleep demand increased, physical capacity declined, and glucose became harder to correct even when diet discipline remained unchanged. Medication effects became more visible, not because drugs caused damage, but because other stabilizing mechanisms weakened. My VPT analyses, combining VMT and TDA, all point to the same conclusion: post-stroke glucose control follows a different structure. Sleep and realistic physical recovery now outweigh further diet tightening. Applying pre-stroke control logic to a post-stroke system risks misunderstanding and unnecessary strain. Metformin no longer has the same effectiveness it did in the pre-stroke period. This article is not meant to criticize medicine or replace medical care. It is meant to share an observation that many stroke patients feel but cannot easily explain about their glucose fluctuations. The body is a moving biosystem that follows mathematical principles and physical laws. When its trajectory changes, listening early is wiser than waiting for thresholds to be crossed. Calm attention, guided by trends and self-awareness, allows safer recovery. That is the message I hope other stroke and diabetes patients can take from my frightening experience. Checklist for stroke patients: 5 daily body signals. Your numbers may look okay, but listen to these 5 body signals first. 1. The gas tank test. Are you running out of energy earlier in the day than before? If yes, your body is working harder than it used to. 2. The bounce back test. When you get tired, does it take longer to feel normal again? A slow recovery means your body needs more rest. 3. Sleep is medicine if you feel worn out. An extra hour of sleep often helps your glucose more than a long walk. 4. Do not force it. Do not try to exercise at the same level as before your stroke. If you feel pain, dizziness, or unusual fatigue, stop. 5. Watch the pattern, not one number. Do not worry about one high glucose reading. Be concerned only if your numbers trend upward day after day for a week. The golden rule: if your body feels wrong, it probably is, even if lab tests look normal. Disclaimer: I write this paper not for fame, but to share what I have learned so others can understand health, prevent disease, and live longer, healthier lives. This content is provided for educational reference only and does not constitute medical advice. No doctor-patient relationship is created. You may share this summary freely, but it must not be altered or republished as your own. All intellectual property rights belong to the author, Gerald C. HSU. This content is provided for educational reference only and does not constitute medical advice. No doctor-patient relationship is created. You may share this summary freely, but it must not be altered, edited, or republished as your own. All intellectual property rights and copyrights for this article and its related materials belong to the author, Gerald C. HSU.